Well, this is the United Arab Emirates. This is George Swan speaking. I'm a hospital administrator. I've been here in the United Arab Emirates since 2007. A little bit of a time off last year. Working currently with the MOPA, the Ministry of Presidential Affairs. This presentation on hospital benchmarking was prepared for MOPA. So I'm going to try to make this a TED Talk in 20 minutes to get through the whole thing, and there are a lot of hyperlinks in here that I probably won't go into for the most part, but you'll see them, and if you want a copy of the presentation, send me an email. The agenda about hospital performance benchmarking is what is it, and why would we bother? I'll tell you a little bit about my experience from SAHA. SAHA is the Abu Dhabi Health Services Company in Abu Dhabi, the government side of hospital healthcare. I'll tell you about some initiatives in the UAE. We'll look at some reliable and helpful models where we can find them, and look at an example of patient satisfaction. We'll see some examples to point the way, and we'll talk about some next steps for the ministry, the medical office of MOPA. So first of all, what is hospital benchmarking? It sounds obvious, comparing one hospital to another, but what data do we compare? What hospitals do we compare? Do we look at bed size? Do we look at specialty types? And what benchmarks are available? And also consider the caveats. This is a wonderful survey that was done by Sanagest, a Spanish company. You can click on and get the white paper that describes all these different benchmarking systems that the author looked at, and this is just a list of all the KPIs that he found in these different systems, and the commonality between all of them is surprisingly very small. This is a vendor, MMTC from Michigan. It's just a nice list of 24 metrics that you'd expect to see in most hospitals, and they, as a proprietary service, invite hospitals to submit their KPIs and share them between those who submit their papers. SEMA, the Chartered Institute of Management Accountants, has a great white paper on governance and performance oversight, and they ask these simple questions. Is the performance that you're considering, the performance KPIs, the key performance indicators, are they material, relevant, reliable, comparable, and so on. They're all very important questions, and oftentimes we look at KPIs and they don't measure up to this standard. But why would we do hospital comparisons? Well, we're curious. We'd like to know what's going on across the street or on the other side of the world. It helps us to see if our own numbers are in the ballpark. We also have to report data to our governance authorities, regulatory agencies like the Ministries of Health. We have to consolidate data that eventually would get reported to the World Health Organization. There's a whole world of national health accounts that's a subject too big for this paper. Worth looking at. We like to look at KPIs between hospitals to see maybe there's improvement opportunities, and those improvement opportunities might help us to budget a little more carefully and see where opportunities exist, how much could be saved, or how many FTEs. We want to look at productivity. We want to look at cost of service, and RCAS is the responsibility and cost accounting system for activity-based costing. that we're developing. And we talked about regulatory requirements of reporting. There's Joint Commission standards, the ORIX standards that are used around the world to measure things like heart failure, infection rates in surgery, a number of core clinical measures, and any hospital that's accredited needs to follow and track those measures. And then there's just making information available to the public, quality indicators that would reassure the public that the hospital is being managed correctly. And the bottom line is pride and performance, recognition of our hospitals as world class and worthy of the public trust. This is a wonderful diagram. It's a hierarchy of Holons, we call that. A Holon simply means that a hospital and a clinic, for the most part, could operate without a lot of contact with the external environment. I mean, they have to get licensed. There's things that they're required to do, but with a minimal of contact, they actually could operate as a silo in the community, in the healthcare industry. And we know there's so many opportunities that we could be involved with that we're not. But the healthcare industry does rely on the hospitals and clinics to report information, and regions and cities and communities that are concerned about their health of their citizens or residents need information from the hospitals and clinics. They can't operate without that information. Country information at for example, the United Arab Emirate level, to compare Emirates side by side and look at the country statistics, and not only to compare to other countries, but to report to the World Health Organization. The GCC countries like to compare against each other, and you can't have that kind of comparison without consolidating data from hospitals and physicians. The couple links on here to the World Health Organization initiatives for healthy cities. There's benchmarking between hospitals in Europe, and there's a wonderful paper by Boston Consulting Group on data transparency and how transparency and openness of data actually increases the value of data within the healthcare system. This is just a list of different kind of indicators at the World Health Organization level. The biggest problem getting timely data reported, and wouldn't it be nice if the UAE could develop a timely system of collecting data on an annual basis. Number one, to report it to World Health Organization and GCC agencies, but also to track information on a year-by-year basis just within the UAE, just tracking year-to-year information by the Emirates. I also want to mention wonderful webinar looking at 3 case studies when health information was made available to a community, how they were able to make a difference. And the fact is, in a community, the hospitals, clinics, doctors, the providers are one spoke in a network, the wheel of communities. The other spokes are education systems, businesses, municipalities, neighborhoods, public health services. In order to do their job, they need information. One of the things that the Healthy Community Institute has created, this framework that Arizona uses very nicely. You can click on that homepage or do a Google on Health Matters at or Arizona State. You will see a very nice system for bringing stakeholders together to improve the health of the community by looking at a variety of indicators across, in their case, in Arizona's case, counties in the state of Arizona. This is just a nice little note from Santa Jess, the one that did the review of hospital performance systems, to just make sure that the data in the hospital is properly validated. And the white paper talks about some of the things you have to consider here. And you know, frankly, there's no point benchmarking to other hospitals if internal data integrity is not assured. Internal tracking of basic KPIs has to be mastered if you're going to be able to have data for hospital comparing purposes. And in the MOPA, the medical office, they have these 8 themes. They're very similar to the Institute of Medicine's KPIs. They're aims in healthcare of safety, timeliness, effectiveness, efficiency, equitability, and patient-centered care. MOPA calls it STEEP. The book is wonderful, Crossing the Quality Chasm. I highly recommend it. You can download it for free if you go to the link. But the hospital has to get it right. You know, avoid having performance reports that are more important than the performance itself. You know, these KPIs are indicators of systems and processes, and you need to think about balanced scorecards. And the top 3 areas that all interlink, if you will, patient engagement, employee engagement, and community engagement. They're indicators for patient engagement that are financial in nature, operational, and clinical quality. There are indicators for employee engagement that have all 3 of these KPI categories. And community engagement also requires the financial perspective, operational perspective, and clinical quality. You know, there's a lot of juggling involved with this data. You can take a look at the link here and see, you know, that it, when properly learned from, you know, the real professionals we have in this field, even, you know, you can juggle very, very well. We use in MOPA, we use a piece of software called Corporator. It's a balanced scorecard piece of software that we use. A great paper on the subject at the link I provided here. And this is just a little network of internal hospital data, and in particular the data registers on the right that measure what we call the big 5, the patient utilization, financial expenses from the accounting side, revenue from the billing side, HR, manpower, staffing, and then the ratios that we can measure, you know, the cost per patient day, or adjusted discharges, and so on, cost per DRG, those sorts of things you can do when you have these registers set up properly. One example that we like to look at is the physician productivity benchmark. We can just click on Excel for a minute, and you know, we can just see here. This is a pivot table that is taken from a master data set with headers, transactions. This is over a 3-month period. We could look at a weekly trend here by doctor, by clinic, by year, and see what are the volumes, how many people were booked, how many no-shows, what was the capacity based on the normal weekly productivity of a physician. If you add up all the physicians in a specialty, what's the capacity for each specialty, and for the hospital as a whole. And this would all be part of the budgeting process. This happens to be outpatient days, but we also need the discharge. We need to get our patient utilization projections based on real physician productivity, to who we're going to hire, or what kind of productivity we expect from physicians. And that would be the basis of all the other departments providing sufficient staff, supplies, equipment, facility to serve the patients in each specialty by each doctor, just to take care of them. This is just a nice use of a pivot table. You really have to master pivot tables to make this work. There's a great article in there about Narayana Health from Harvard Business Review. The efficiency that they've accomplished is 10 cents on the dollar. They just put a 2,000 bed hospital in the Cayman Islands. They're building it. Eventually it'll be 2,000 beds, and our primary clientele will be Canada and the USA. They'll just bring patients down there, take care of them with very high quality marks, and because they specialize and they've turned it into a nice kind of a machine. Interesting to look at some of the measures of visits per week, visits per day. In the U.S., this is 73.6 visits per week that this proprietary database showed. A couple of the hospitals I've been working at this year are half of that. And these are measures of compensation. Just shows that somebody could be very highly paid, but their productivity is below par. And on the other hand, other people who are being paid a lot less, whose productivity may be much higher. Obviously, we need more than these worked relative value units, WRVUs. We need to know clinical quality indicators, and what kind of support resources are developed for physicians. But knowing these numbers, we can help facilitate productivity in our own hospitals. I'll just point out the Medical Group Management Association is another proprietary source of practice comparison data, well worth looking at. This is just to give an example of a couple of data sets in the USA. CDC has a huge warehouse of data, including data from the behavioral risk factors surveillance system used in most states. You have to go there and try to access data for yourself to find out how difficult it is to actually find the data that you want and look at some real comparisons. And I actually haven't found it by hospital, but interesting data. For example, this data about emergency department visits, 27% less than 15 minutes, 70% less than an hour. That's much less standard than what we've expected from our hospitals in the UAE. On the other hand, we'd like to see a breakdown by the level of triad, L1, 2, 3, 4, and 5, and just see how does the timing compare by triage type. That's something most emergency room professionals, nurses, doctors like to see, watch, and make sure you can get them in, get them out, take care of those patients that come to the ED. I'm just going to mention this is the IHI, the Institute for Healthcare Improvement in the USA. This is a wonderful improvement map of areas that can have KPIs related to it, and you can't really deliver the appropriate service in each one of these areas without data. That's the bottom line. I mean, this could be a like a poster on the wall, and it could be red, yellow, green lights on it, like a heat map. It'd be excellent. This is just making the same point that in Utah they have this health information exchange, and these are just the key stakeholders. Again, each box requires data to be made available to the system, in order to provide the service that these people would all like to see. Hospitals and doctors have to be very heavily involved in this sort of system. It just doesn't work, without the providers. Talking about health information exchanges, this is a great link to, if you go to My Health Oklahoma, you'll find a homepage, you'll find a wonderful YouTube. The best I've seen, a 30-minute YouTube that tells you, really what is the intent and the purpose for health information exchanges. They can't work without the input from hospitals and doctors. That's the bottom line. This is an example of Saha when I was working with this large hospital with a large hospital network. We had 6 large hospitals, 6 small hospitals. This is just the trend of what I call the big 5 in an executive profile. Every hospital should have these things: utilization, staffing, expenses, revenue, and ratios. This kind of information comes from the hospitals. We could do a side-by-side, for example, in 1 year. You could do this monthly. I collected the data monthly, side-by-side, and that gave the corporate monthly. When you did the monthly trend, the corporate, that was the budget, or helped us develop the budget for the director of finance. Without this information, you just could not rationalize your budget monitoring responsibilities. Here we're just talking about KPIs, priority area. We used a system called Septimia, same thing as the STEEP before, again from the Institute of Medicine. But we did side-by-side numbers. We could total them up, look at the targets. These were our 9 aims of healthcare delivery in Saha. We added the 3 additional ones in addition to safe, effective, patient-centered, timely, efficient, and equitable care. We said, well, it should be measurable to world-class healthcare. Again, where are the benchmarks? And innovation should be, we should be measuring our innovation ability to bring in new technology and to do research to provide better service to our patients. And then, having data that's appropriate to the culture and the government, because every community is slightly different, and certainly countries over here in the Middle East are far different from what you'd have in Europe, Australia, USA, and so forth. This is a nice little chart that I got about the UAE framework, and this is kind of how it is. The Ministry of Health taking the northern zone and sort of doing everything, but I actually prefer to look at it in a slightly different way. Let's take another look. If you add in at the top the National Bureau of Statistics and you go to the link, you want to see, what all the different statistics for the country that are really needed by the stakeholders from different perspectives. But you've got the Ministry of Health here, who is the key representative to the World Health Organization and the GCC. They're overseeing the regulatory agencies of the Emirates, the Health Authority of Abu Dhabi, the Dubai Health Authority, and then on the right, the Emirates Health Authority that oversees 5 small Emirates in the northern zone. And then down in the bottom there, the providers from Saha in Abu Dhabi, the providers in the Dubai area, and then the providers in the northern zone. And this little network is critical to bring data from providers together, to organize it for population health, and to provide data appropriately to stakeholders. This is just an interesting slide to look at. HIMSS Analytics, they collect data to measure IT systems in hospitals, and it's a proprietary database, but in order to really make it meaningful, they need information about the hospital, so they collect from their members this kind of data. And this is the normal kind of data you'd see in an executive profile, and why they have to collect it from the members as opposed to downloading it from some kind of a government website of the hospitals in each country. It really surprises me. It's not just the UAE, it's the USA, Australia, anywhere you go. This kind of data is very, very hard to come by in any kind of standardized fashion. This is what you get when hospitals do report information to the authorities. This happens to be in the Northern Emirates, and if I look at a particular emirate and we put a hospital up there, can the hospitals be combined, or what's going to be the total bed utilization? We really need to be looking at the community health need assessments, and they have a great model in the USA. Go to CHNA, Community Health Need Assessment Board. They have accreditation criteria now that is developed since Obamacare has come in. It's mandatory of all hospitals to do this with their community. It's a great way to begin with all stakeholders in a community to begin to share data and work together to improve the health of the community residents. This is a link into Health Authority. So they've just announced in the newspaper the development of this quality metrics program. These are the values and the vision of the Health Authority in Abu Dhabi. They have an all-payer claims database called Shafafia. You can go to the link. All of these little squares require data from hospitals and doctors and clinics, and you just can't get it done without them. This is just another breakdown of looking at data quality, of core clinical quality, for example, the provider quality information, access to information of the residents, supply and demand information, cost information, reimbursement, and the cost of capital, developing new hospitals, building new hospitals, getting new equipment, new technology, is it cost justified? And this is just an example of one page from the annual statistics report. Where do they get their information? Doctors and hospitals. Again, it's kind of interesting. If you divide 13.2 million encounters by 4,757 physicians, you get this about 53 visits per week. And remember, the other one we were looking at was 70 to 80 in the MGMA area, and the hospitals that I've been working at are down about half of this. So we need more information about what is a good productivity represent for a good physician that's providing quality and efficiency in their clinic services. And this is just a clip from the newspaper reporting 2013 data. The important thing is, again, when you look at this data, is it easily accessible to, this is from 2013, and it's just being reported in December. Really, we should have timely information that's much more available to the key stakeholders, even on a monthly basis, would be outstanding. And again, they're looking at the four primary areas of patient safety, effectiveness, timeliness, and patient-centric care. This is just a letter about the Hospital Quality Indicators Project. They're going to concentrate on 10 metrics. It's great to have those 10, but if we look over here in 2011, Thomson Reuters was developing a network of hospital ratings. They looked at all of these databases on the left: Australia, CDC, Medicaid, Medicare. They looked at some NHS indicators, and that was in 2011. They had 139 indicators, and I just think 10 metrics is really under asking, that we really can get a nice set of indicators that's standardized for hospitals in the UAE that would be very easy to collect, and it's not putting the hospitals under a microscope. It's actually partnering with the hospitals for the benefit of the community. You know, there's a paper about you know, when KPIs become toxic. I might have time to look at that. But I've looked at these countries: Scotland, Canada, U.S., Australia, United Kingdom. You can look at these yourself. Just dig around and see, can you find easily indicators for hospitals to compare them to? And I think you're going to find that a lot of these indicators, even though they're available, the way they're put forth or put up on the internet, they're very, very difficult to see and use and download and, you know, think about. You just take a look for yourself. Vendors have data warehouses. So Dr. Foster's in the UK, you know, they put some indicators up, but if you want to hold the whole data, you need to join it. You need to work with them internally, and it's kind of private information for the most part. Again, go there and look and see how easy is it for you to compare all the indicators for any hospital against another hospital. UHC is the University Hospital Consortium, about 180 hospitals in the United States. They've joined up with Foster, and they've got this proprietary database. You can't look at it unless you are a member of it. DataBank does 35 states. I'm from Colorado, and the Colorado Hospital Association submits data, very private. You can't get it unless you're a member. The Hay Group in Canada does similar sorts of things. American Health Directory will look at. Medicare uses their data for hospital compare. Again, you just have to go there, and I challenge you to find information easily that you could do a pivot table with. We'll let the cat out of the bag. We're talking about pivot tables. This is Foster's University Hospital Consortium, Canada. This is, I love this site, American Hospital Directory. You can look at a little profile, just click, and you've got a map, you've got phone numbers. This is the sort of thing the AHA should provide, but the AHA is all proprietary. And you can't go to the American Hospital Association and get this kind of information just clicking from one to the other. But on the other hand, American Hospital Directory, even though they've got all these wonderful indicators, you have to buy it. And, you know, it's probably worthwhile to get this once a year and get the hospitals that you need to compare against, download them, and then make your little own data warehouse. But, you know, why don't they offer that to, you know, to the world? Just make this data more easily accessible. This is AHRQ, research and quality, healthcare research and quality in the U.S. You don't have to have a big debate in your hospital about the definition of measures. You can download these measures, and I'm sure you're going to find out they've been vetted by professionals, and they're very carefully done, and it's a whole data dictionary. It's well worth downloading here. You know, don't reinvent the wheel if you don't have to. This is a great link. This is an all-payer claim database state, Colorado. I'm from Colorado, and there are about 10 or so states in the USA that are developing this kind of information. You know, I love this, and frankly, we could just take a look at an Excel database right now. If we, for example, let's see. Here's some data that I downloaded. Now they had separate Excel sheets, one per year, and they had all these headers, and I think I've got the fields here. So they've got the total cost of care per resident in one of 60 counties in Colorado. They do this from all of the claims for services that are submitted into the warehouse. You can break that total cost of care into inpatient costs, outpatient, ER, physician, ancillary, and drug cost. You can look at the percentage of drugs that are purchased, and it's got an index here as to whether they're higher or lower than the Colorado state average, and you can see other kinds of indicators here. If you compare these counties, you know, you can use these little slicers up here. So if I want to look at 2010, I can just click on a little slicer. You'd have to go into a YouTube and just do look at any video in YouTube about how to make a pivot table. This is how the data should be made available to everybody, stakeholders from all these sites that have these public warehouses. They're so easy, and you know, these are the counties. If you click on, you know, a couple of counties, if I want to compare Logan to Lincoln to Los Animas, I just control click. There I've got the 3 counties. I can compare their cost of care. If I want to add in, you know, Denver, I can just control click that. I can add Denver, and you know, it's so easy to do these side-by-side comparisons. And if I go, you know, into something like this, for example, I can look at these major averages of cost of care, for example, and I just had a list here of the counties. I sorted them from high to low. This is the average of the high 10, and this is an average of the low 10 counties in the state of Colorado, and this is a breakdown of their averages by type of cost. And you know, you here's Mineral County, $5,000 per resident, and you're down at, you know, here's Denver, and it's $1,750, right? You know, all these other counties are doing care for half of what Mineral County, Baca, Pitkin County are doing. Why? You want to know why. And if you have information about the age and gender, you know, it's easy to compare information when you have a pivot table. That's all we're going to say about pivot tables right now, but that's an example of, you know, how this looks. They get their information from the behavioral risk factor surveillance system we talked about before. It's run by the Colorado Public Health Department. They can't do that data without hospital and doctor information. I'm just showing you this for an example. We got this from some almanac that's all proprietary, but you know, having these percentiles, top 10%, top 25, you know, that's the way we should see information, is by percentiles. You know, this happens to be the what we call the HCAHPS percentiles, a top box and a bottom box. The Hospital Consumer Assessment Survey. All hospitals in the USA are required to survey every patient that is discharged from the hospital. So this information is available on a year-by-year basis for every hospital. It's reported at the state level. It's reported in Medicare's hospital compare system. But again, if you go to the data, it's not in pivot table format, you know, and it's very, very difficult to find this in a pivot table that allows you to, you know, select and sort, to mix and match and slice and dice information. It's there, but you're going to pull a tooth to get it out. This is Ohio. I don't have time to go into it, but they have a great download of a lot of information. In fact, let's open that. This is the Excel information. Again, if I go to the data in the Ohio system, I have a year of data. I could take 2011 as well and tack that on below, and 2009, 2008. They go back quite a few years with this data, but they don't This is simply a flat file, a comma delimited file. I've uploaded it into Excel. I've made a pivot table out of it. And now I can look at a knee replacement by hospital, and I can see, what's the surgical site infection rate. I can sort it by high to low. If I go to the HCAHPS information, I can sort this again, high to low. I can look at all these facilities. Here's the Cleveland Clinic Foundation, about in the middle. There's hospitals doing 100%. Over here, this is recommend. Would you recommend this hospital to your friends and family, which is the number one question they assert represents the best measure of patient satisfaction. So here's 86% at Cleveland Clinic. There are hospitals up there over 90%. And, if you come down here, you have some hospitals that are, would you go to OB-NESS Memorial Hospital? Probably not at 11%, but they're down there 50%, 60%. I mean, these hospitals need some help in employee engagement, I would say. But maybe one of the reasons that they're not doing better, they don't have this information that easily readable. They're kind of a mess internally, and the oversight from the Ohio Public Health, Ohio Hospital Association is just not there. So we're just going to kind of move forward a little bit more. This is just a printout again of, kind of a result you would get from a pivot table. This happens to be county health rankings in Wisconsin, but again, it's very difficult to pull this information out by the 3,300 or so counties in the USA, but you can pull it out by state, by county. And I found it, I extracted it. I made a nice pivot table. If we had a little more time, I'd go and show you. If you get this presentation, you could look at it. This was, sorry, that was a little fast. This is just in the U.S. Press Ganey does a comparison of hospital data that they pull. It's all proprietary. They create this system of an index of care, but it's proprietary. They'll talk about the methodology, but it ought to be much, much more open. This is from Hospital Compare. I could easily go on there. I could look at this information from a particular hospital. It's all PDF format. It's not a pivot table. It's nice information, but again, it's pretty spread out and not so easy to, to use for, I would call them business intelligent professionals. Intelligent professionals and business intelligence professionals. And this is Joint Commission, so they require these core measure sets, what we call ORICs. And again, if you go in and look, you see you've got all kinds of information, and it's required for accreditation. And this wonderful, wonderful database. But, you have to select a hospital, you have to pull it up, and then you get to see data, kind of one little sliver at a time. It's like looking at the sky at night, and somebody gives you a straw, and you get to look at the whole sky with a straw. And, you might find some bright stars, but you do not appreciate the entire universe when you have to look at data this way. It just does not work. We talked about the American Hospital Association already, and it's all proprietary, $6,000. You can download the information. It's worthwhile. Probably most people, don't really do so because they don't know quite what to compare. And every hospital, we got about 5,000 hospitals. If each one buys this report, that's a lot of money. And this is the American Hospital Association. They ought to do better to provide pivot tables of basic information of all their hospital in the United States for free. Frankly, just let people download information that's commonly used. This is a great site. Again, I won't click on the Excel, but if you go to California, they standardized all the downloading of hospital cost reports. You can click on any one of these boxes, look at the Excel sheets. They've got a lot of pivot tables in there, but they're not select, sort, slice, dice, mix and match. They're actually, if you want to look at a hospital in certain ways, it'll give you the whole report back of raw data and a bunch of calculations. It's nice, but you really have to go back to the raw data and make your own pivot tables, and definitely you can do it from their site. Very informative. Again, they make the public, the stakeholders, jump over a lot of loose bricks to get information that would be very, very helpful for side-by-side information and selecting hospital to compare. This is New Zealand. They do a great system for their districts. You can click on a district. Again, you can see you can get it by PDF. You can get it by Excel format. You just have to go there, and I think you'll be able to predict what I'm going to tell you. Not too easy to work with. They should have a couple of pivot tables of all their districts and their key measures. You should be able to download it and slice and dice, select and sort, and mix and match with pivot tables. This is their scorecard. They're developing it still. Just a pilot kind of format, but it just tells you you don't need too many indicators in a balanced scorecard kind of approach. But you cannot do this for New Zealand, for the Ministry of Health, for districts, for communities, unless the hospitals and the doctors are sending up the data. It just doesn't work. This is the National Center for Health Statistics. Huge warehouse. Tons of data. Go on it. Try to get some pivot tables. It's next to impossible. Again, I think if you're a business intelligence professional, you probably would master this, learn it, and develop, some kind of a. I think they download it into SAS and Access or some other kind of system, but it takes a lot more work than you would need if you had pivot tables. This is a example of a side-by-side for a year of our facilities when I was working with Saha. Pardon me, Saha, if I just share this a little bit, but I did not know pivot tables at the time I was working at Saha the way I know them now. I want to show you, if you take all this information on a monthly basis, on an annual basis, and you put it into a pivot table, that you can actually create this kind of information. So here is a side-by-side, for example, in 2011. If you wanted to look at the actual in 2010, there it is. You just click on the year, click on the year. If you want to look at the budget in 2011 that was final approved by the Director of Finance. If you want to look at the budget for 2012, this information was developed in 2012, and then we projected 2013, 2014. You can look at all that information and see how it goes together. If you want to deselect it and just have the whole thing, now you have the annual for a particular facility. Now I could look at AHS, Alain Hospital, Garbia is the Western Rural Hospital System, Corniche Hospital. You just click on a hospital and you get the entire year in a trend format. It's just amazing. This is what it used to look like when it was a flat file. And I used this. It helped. It was great. But these little pivot tables are extraordinary. And I just urge you to, think about how helpful they are if you set them up as pivot tables. They're enormous. And then down here, this is North Carolina and some of the detail that they're looking at some great things, but again, no, not terribly useful pivot tabling, but some good ideas in here. Next steps for the medical office at MOPA, Ministry of Presidential Affairs. Internal data at the hospital has to get developed. If you don't have that data in the hospital working properly, you're not going to go out and do any benchmarking. Again, get the data uploaded to our balanced scorecard system. Produce that executive summary of the Big Five on a monthly trend basis. It'll help you with the budgeting and help you with the expenses. Develop your revenue and cost accounting system. You have to have a standardized chart of accounts. You have to know what you're doing to work with this. But the main thing is departmental engagement. If you do not distribute your Big Five information by department, you cannot develop a departmental engagement. And if you do distribute information on a monthly basis to departments, they'll develop their own monthly trends, the Big Five, their workload units, their staffing, their expenses, revenue if they're a revenue producing department, and ratios. Doctors absolutely need to see their clinical services utilization on a weekly basis. Chief of service just can't do justice to working with the hospital if they're not getting regular weekly information, monthly information to help develop the basis for the budget, which is all services to the community. You have a doctor that produces surgery cases, ER visits, outpatient visits, procedures, and each doctor, you add up those services to a clinical service. You add up all the clinical services to the hospital. You've got to have that information for a hospital. And employee engagement, if departments are empowered, employees will get engaged. I'm talking about the Gallup poll Q12 employee engagement system. If you don't know about that, take a look at it. Patient engagement, it doesn't work without clinical quality and without activating the family and getting the family involved, getting the community involved to be as healthy as they can be. Externally, the medical office could start working with the Ministry of Health, the Emirates Health Authority in the Northern Emirates. They could start working with the Health Authority of Abu Dhabi. Get involved with their hospital indicator project. Get involved with SAHA. NMC is one of our hospital contractors. They absolutely should be part of a consortium for hospital compare in the UAE. The enrollment of Dubai Health Authority, the Minister of Health for the UAE hospitals is critical. And if you create data transparency, this is something for MOPA hospitals, SAHA hospitals, all the hospitals should be putting pivot tables on their websites, and the pivot tables that the health authorities have should be a link from the hospital into the health authority, into their communities, into the country, into the GCC measures, and help people get engaged by providing information about healthcare to everyone concerned. Again, basic decisions for MOPA. What are the most important data to benchmark? Who are you going to benchmark with initially? SAHA, Health Authority, Ministry of Health hospitals. You got to decide how you're going to collect the data, what format. Keep it simple. Make pivot tables for your key data registers: patient utilization, HR, expenses, revenue, and ratios, the Big Five. Just do that. And then those core clinical indicators that we have from all our hospitals being Joint Commission accredited. And access and ownership. Who should have the data? Don't be shy and realize that when you make data transparent and open, it will improve itself, even if it's a little bit off and not quite accurate to begin with. Making it public almost doubles the validity and accuracy of the data itself. But you hide that information, it will start to fester. That's the nature of data. So make it public, bring it out in the open, and let people see what it is. It is what it is, and you can't really work together unless you're willing to, be embarrassed a little bit when you see data that's not as good as it should be. It opens the door to a possibility for improvement. How frequent? Well, I think hospitals ought to have a standard reporting frequency of monthly. But we do get birth data on a real basis as babies are born. We ought to make use of our birth register or death registers, death certificates, standard data. We ought to have some pivot tables in there that are available to the public, and share it with external stakeholders, including the media. Because if you don't give them accurate access to accurate information, then they'll use whatever happens to pop up, and unfortunately, that data that they get as best they can is limited accuracy and questionable, and then people make all the wrong decisions. The recommendations, I'll just let you kind of read those, but the key ones we've already spoken to. Develop a consortium. Start working with your agencies, your other hospitals. Publish your key statistics on your websites. You can do that without anybody else telling you yes or no. Get it up there. And look at this all-payer claim database that the health authorities developed. A rich database for DRG analysis, for productivity analysis, supply and demand. And, if you can get that into pivot table format by hospital, start making that available, it'll be worth its weight in gold. It's a wonderful opportunity for all of you. And with that, I'll just conclude. Thank you very much. I'll just say there's, two kinds of leadership. There's leadership that you know about, and there's leadership that you show. Leadership is definitely being in action. There's a wonderful course in Dubai from the 7th to 13th of January. If you happen to see this before the 19th of December, that's the latest registration date, then go there for more information and register for a wonderful course that will change your life. And you can email me for a copy of the presentation, and I'll send you a couple of Excel pivot tables you can look at. But start experimenting, see for yourself, and thank you very much.